Hello, my dear future nursing officers. I welcome you all once again back to the Master Nursing classes. Dear students, in the last very important session, we have discussed lots of the important image-based questions and the clinical questions and the concept-based questions. So that is much necessary for our exams from the basics of the eyes and especially on the investigations what we are doing in the eyes. Okay, so by quickly revising all the very important things, so I'm just going to take a very few minutes to revise all the things what we have studied in the last class, and we are going to continue with the next class that is in a very perfect manner. Okay, so we have the less time, so we don't have the time to waste, and time is not for made for the waste. Time is there for the utilize, and time is there for the improve, time is there for the progress. Okay, so don't waste it, don't scroll the rolls, and don't skip the video in middle. If you are starting the video, if you want the selection, complete the video, take a handwritten notes. Yes, it is hard, it is difficult, but it is beneficial. Okay, so let's begin this very important session by quickly revising the a few topics which we have discussed in the last very important session. Okay, so can you able to see what is this one? Are you able to see the image which is there in front of you all? So this is then the a very important Ishihara test. So for what purpose we are doing this Ishihara test? So this Ishihara test is done for the purpose of assessing the color blindness. So color blindness, so we are assessing here. So that is very important for your exam. Okay, so here we have the most important test what we have discussed in the last class. Okay, so that is started from here. Okay, so which instrument which we have used for the measuring the intraocular pressure? So that is the tonometer. Okay, in the tonometer we have the two type. One is contact tonometer. Directly we are putting the base of this tonometer instrument over the cornea. So here the topical anesthesia is required because we are directly putting the base of the tonometer on the cornea, so it will irritates, and we are applying the topical anesthesia. There is loss of the sensation is there over the cornea. If patient is rubbing, so patient will not get sensitivity of that one, and he will rub more, so there is a chance of the ulceration of the cornea or the damage of the eye. So that is the very important thing. After the topical anesthesia application, avoid the rubbing after the topical anesthesia. This is the golden point for your exams. Okay, yes sir. So here we have the two types of the tonometer I told. One is the contact tonometer. This is the gold standard one, and this one will give the accurate result. Another one we have the non-contact tonometer, or we also call this one the air puff tonometer. Okay, so this is the non-contact tonometer image. So here there is no contact between the eyes and the tip of our machine. Okay, so here we have the gap, so no need of the topical anesthesia. This machine will suddenly blow the a tuft of the air suddenly inside, or the puff of the air will be suddenly blowed inside the our eyes, and it will measure the intraocular pressure. Okay, that we have done. Okay, so rise intraocular pressure, what we called, so we call that one as the glaucoma. Okay, and we have discussed the question on the Snellen chart. So this is made for the assessment of the distance visual acuity. For the assessment of the near visual acuity, what we have, so the near visual acuity we are checking means, so that is we have the Jaggers test. Okay, so Snellen test, this particular Snellen chart, this is used to measure the distinct visual acuity, not the near. Okay, so for the near visual acuity we have the Jaggers chart. Distinct visual acuity, Snellen chart. Okay, so it contains the rows of the letter which will gradually decrease from the top to bottom. What it means, sir? So this chart is having the big letter here, then small letter, then small letter, then small letter. Okay, so big to small from the top to bottom. Okay, but in a Jaggers test, that is the small to big, so that is from the top to bottom. This is our Snellen chart what we have. This is our image based questions which can expected. Okay, so here we have the big letter, and here we have the small letter, so that is very important. So this is the most importantly we have to understand, and the standard distance between the patient to the Snellen chart should be 6 meter or the 20 feet. Okay, 6 meter or the 20 feet. Normal vision will be 6 out of 6. Okay, or 20 out of 20 feet, or the 6 out of 6 meter. This is the normal vision. Okay, so the most importantly, while assessing with the Snellen chart, what we have to educate to the patient, close the one eye and look by the only one eye. Okay, so one eye we have to check at a time, so another eye should be closed at that time. Okay, so if the visual acuity, if it is coming 6 out of 60, so this means, what is this means? So it means a normal person can see one object from the distance of the 60 meter, and here the patient can able to see that object from the 6 meter. If we are making that person to stand at the 60 meter, he is unable to see. Okay, so when we will bring him to close to the object for 6 meter, that time he is able to see. So if I am able to see one object from the 60 meter distance, and the patient is unable to see that one, and he is able to see that one only from the 6 meter distance, so that is what I can say as in the legally blind patient or the severe visually impaired patient. Okay, so this is even after the corrective lenses. We given the glasses, we given the contact lenses, and we given the better surgical treatment. Even after that one, if the visual acuity is coming 6 out of 60, so this is the severe visual impairment, what I can say. Are you getting? Yes, sir. Criteria of the legal blindness we discussed. Visual acuity is the even after the best correction, so there is in the 6 out of 60 is there, or the 20 out of 200 is there. So that it means I am able to see, I am the normal person, I am able to see one object from the 200 feet distance. So the patient is unable to see that one from the 200. So he is able to see that one only from the 20 feet. So that is what we can say. The patient is able to see from 20 feet and the normal person able to see from that one 200 feet. Means, so the patient is unable to see from the 200 feet. So that is what I am going to explain here. Okay. So that is the what we will check in the Snellen chart. That is the visual acuity, distance visual acuity 6 out of 60 meter or the 20 out of the 200 feet. So this is what we can say legally blind patient, and visual field we are checking. So if it is less than 20 degree, that is called as the legally blind patient. Okay, Jaggers test we have here. So this Jaggers test we have checked for the assessing the near visual acuity, distance visual acuity by the Snellen chart, and near visual acuity by the Jaggers test. So this one we have already explained in detail. And here in the Snellen chart, the distance which was standard distance between the patient and the chart should be 6 meter or the 20 feet. So here only about the 35 to 40 centimeter. Okay, for example, consider, so I am holding one book or one notebook like this. Okay, so how much is the normal distance I have to hold this one? So this normal distance I have to hold at the 35 to 40 centimeter. Okay, this is the normal distance what I have to hold, and this same distance we have to maintain in the Jaggers test. Remember, okay. So because here we are holding near and we are reading perfectly. If I am able to read this one by holding the 35 to 40 centimeter, means my near visual acuity is very perfect. Okay, so I hope it is very much clear to everyone of you, right? Yes, sir. So this one is used to measure the near visual acuity. This is where used to measure the near visual acuity, and the distance between the chart and our eyes should be 35 to 40 centimeter. This is the very important, and this is what I told about the Jaggers test. Okay, so this is what I have told about the Jaggers test. So in the top it will be small words, bottom it will be big words. Okay, so this one we will consider as the J1, J2, J3, J4, J5. If the person is able to read a J1 very perfectly with a 35 to 40 centimeter distance, so his near visual acuity is very best. Okay, so here near vision is very best. Okay, that is what we have to check with a very important Jaggers test. Okay, so Jaggers chart containing the paragraph of the sentences of the different print size. Okay, so the vision is recorded as J1, J2, J3 and etc. Okay, so J1 indicates the small print and best near vision. If the patient able to read the J1 paragraph, so that is the smallest print he is reading perfectly, means he is having the best near vision. Okay, and next comes to the question on the Ishihara test. Okay, so this was the Ishihara test. What purpose we have used? So this one we used for the purpose of the color vision deficiency identification. Okay, so that is what I told. So we are going to give the different color coded plates. This is called as the Ishihara plates. Okay, so in the Ishihara plates, there are the hidden numbers are there. So check your visual acuity, sorry, color blindness are there or not. Okay, so what is the number which is mentioned here in this plate? So 16. So 16 in the sense, this one I am able to identify. It means my eyes are clear. Okay, so I don't have the color blindness. Okay, if I am unable to identify this number, means I have the color blindness. Okay, so like this, you see, it is the 13, right? So 13 in the sense, I am able to identify the hidden number which is there in the this particular Ishihara chart. Means I am able to identify the colors, different colors. So that is Ishihara test is used to assess the color blindness. Okay, so for assessing the or to identifying the number inside this particular chart, how much time we are giving to a patient? Remember, we are not giving 1 minute, 2 minutes, 3 minutes. It is 3 only seconds. Remember, okay, so how much time we are giving? We are giving only 3 seconds. Okay, so in the option you will get 3 minutes, 3 hours, 3 seconds. Choose the answer as the 3 seconds. Okay, very important. So we are giving the 3 seconds to identify at one plate and to tell the hidden number which is inside there. Okay, so that is very important. This is the Ishihara test what we have. Okay, so I hope it is very much clear, right? So normal result we have is the normal color vision, which means patient is correctly identifying the number, and the abnormal result, it means the patient can unable to identify the number. Okay, so he is telling us a different number. Okay, so people with color deficiency may see the different number or may not see the number at all. Okay, so this is the abnormal Ishihara test result what we can say. So I hope it is very much clear, right? Yes, sir. And this was the assignment question which is there for you all in the last class. So I hope it is very much clear. So this is question on the ophthalmoscopy. Okay, so this is very important for the exam. This is very important for the exam. Right, so choose the correct answer. Ophthalmoscopy is used to examine which part of the eye? So this one is used to examine the fundus part of the eye. So this is the correct answer. Sir, what is the fundus part of the eye? It is not used to examine the external cornea, and it is not used to examine the lens also and conjunctiva also. This lens cornea is the most anterior portion of our eye is the cornea, and only transplantable part of our eye is the cornea. And this is the transparent and avascular structure which is not having the blood supply and which is getting the nutrition and oxygen by the aqueous humor. That is what we call as the cornea. Okay, so here we are not checking the cornea with the ophthalmoscopy. So then what we are checking, sir? We are checking the innermost portion of the eye. So that is we are checking the retina. So in the retina, what are the things we will see, sir? We will see the retina and retinal vessels and macula lutea and optic disc. So these all things, retina, retinal vessels, macula lutea and optic disc. So RRMO. So this is, or you can say as a ROM R also. Okay, so this is how we have to remember. Okay, so this is the, we have the retina and retinal vessels, optic disc and macula lutea. So these things mainly we are focusing. Okay, we'll see other thing also. So these things mainly we are focusing in the ophthalmoscopy. Okay, so ophthalmoscopy we also called as the fundoscopy. Okay, so here we are seeing the fundus portion of our eye. So we also called as the fundoscopy of the eye. Okay, so this is very important, and the interpretation and the chart what I am showing to you and what I am discussing to you, so that is most important now. So please do pay the special attention on the chart when what I am explaining to you. Okay, so ophthalmoscopy is the very simple thing. Ophthalm means that is the eye. Scopy means visualization, which is visualization inside portion of the eye. Okay, so mainly and mostly what we are visualizing? We are visualizing the fundus portion of the eye, which including the retina and retinal vessels and the fovea. So macula lutea and fovea centralis also we can see, mainly macula lutea, and most importantly we are going to see the optic disc. Okay, so that is very important we have here. and this is the correct answer, right? So what is the ophthalmoscopy? Ophthalmoscopy we also call as the fundoscopy. So this is the diagnostic procedure we are doing. So this is used to examine the internal structure of the eye. So what we are checking here, we are checking the internal structure of the eye, especially the fundus. So the fundus includes what all structure? The fundus includes the retina, retinal vessels, optic disc, macula. Okay, so these are the structures. Okay, you can see here. So here is the ophthalmologist who is looking at the beautiful eyes. Okay, so what he is looking, he is not looking at the cornea, he is not looking at the lens, he is not looking at the like eyelashes, eyebrows, conjunctiva and the sclera. So what he is looking here, so he is looking the most innermost portion of the our eye. So this one, okay, so this is what you call as the fundus. So here we have the retina. This what are the things you are able to see here on the screen? So behind me, so this is the retina, and here we have the optic disc. Here we have the optic disc, from where the all the retinal blood vessels will enter, that is the artery will enter and vein will exit from here, and the nerve will get exit from here. So this is the optic disc. So we also call this one as the blind spot. So what we call this one? So we also call this one as the blind spot. Sir, why, sir? Why? Because the entire retina what we have, that is the sensory neuronal layer of the our eye, that is the retina, which is having the rod cells and the cone cells. But here in the optic disc we don't have any rod cells, we don't have any cone cells, so there is vision is not possible here. So here the particular area is blind. Okay, that is what we call the blind spot. Okay, most importantly how to understand. And here we have the a yellowish portion, that is the area which is there here. So we call this one as the macula. So inside the macula there is depressed portion which is having the highest cone cells, that is the fovea centralis. So fovea centralis is the depressed portion which is there in the macula lutea. So this fovea centralis is responsible for the highest visual acuity, because this is having the highest concentration and highest number of the cone cells. Cone cells are responsible for the color vision. Cone cells responsible for the central vision. Okay, so you have to remember, I told already with the mnemonic in the first class, cone cells for color vision, cone cells for central vision, color vision, central vision. Okay, and cone cells is for the bright vision. Okay, so this is for the bright vision or the daytime vision. Okay, and we have the rod cells for the rath vision, that is for the night vision. Okay, so rath vision or the night vision. Okay, and rod cells is for the peripheral vision. Okay, so it is not for the central vision. So rod cell is for the night vision, and this is responsible for the peripheral vision. Okay, and in the fovea centralis we have the abundant cone cells, so it is responsible for the central vision and the color vision and the bright vision and the morning vision. So the maximum visual acuity will be seen in this particular depressed portion in the macula lutea, that is the fovea centralis. I hope it is clear and very much clear to every one of you. Okay, so these all things we are going to see here. Okay, so now suppose you consider we are looking at this particular optic disc. Okay, so here in the optic disc, so this disc is bended inward like this. Okay, and here the swelling is there. In the optic disc the bend is there like this and the swelling is there. So what we can call this one? We call this one as in the papil edema. We call this one as in the papil edema. The very important. So what is the papil edema, sir? Papil edema is the bulge of the optic disc or the swelling of the optic disc which is bulged inside the eyes. So that is what we call the papil edema. So where it will be classically seen, sir? This will be classically seen in the increased intracranial pressure. So this is your 10-star word and examiner favorite word. Okay, so very important. Papil edema will be seen in the increased intracranial pressure. Okay, yes sir. So now suppose you consider it is not bulged inside, it is bulged outward, and which is like a cup, so it is bulged outward and cupping of the optic disc is happening, means so inside the eyes the pressure is increased, that is the intraocular pressure is increased. So beta, inward bulging of the optic disc, that is called as the swelling of the optic disc, we can say. That is the papil edema, which is due to the increased intracranial pressure, not intraocular. Focus, it is due to the increased intracranial pressure. And the cupping of the our optic disc is happening, so that is what we call as the increased intraocular pressure. Means when inside the eye the pressure is increasing, it will pull the thing out. Okay, so the outward bulging is happening, so that is what we call as the cuffing. So that is seen in the IOP raised, that is in the glaucoma. Okay, so I hope it is very much clear, right? Yes sir. So these all are things are very important for your exam. So what the thing we are using here in the fundoscopy or in the ophthalmoscopy, that's the ophthalmoscope we are using. Okay, and what are the structure we are seeing? Retina, retinal blood vessels, macula luteus and fovea centralis, and the optic disc. And here we have the very important table for your rapid revision and the very perfect revision. This is the very important for your exam. Okay, so please do keep in your mind, right? Yes sir. So here I have already told that is the papil edema, which means swelling of the optic disc. So that is bulged inside the eyeball. Okay, inside the eyeball bulging of the optic disc is there. Okay, so this is called as the papil edema. So this is called as the papil edema. Do you want to want me to draw a diagram of this one? Yes, I will draw, so it will give the more clarity. Okay, so here we have the beautiful eyeball. Here what we have? So we have the beautiful eyeball. Okay, so the most anterior portion of the eyeball, what we have, this is what we have is the cornea. What we have? The cornea. Okay, right? Yes sir. This is what we have, the cornea. Okay, and here what we have, the iris. This is the iris, this is the ciliary body. Similar, same here also we have the iris. Okay, so here we have the ciliary body. Okay, so from the ciliary body it is continuous like this, so this is called as the choroid. What is this? This is called as the choroid. Same also here we have, this is called as the choroid layer. Okay, so this particular cornea which is we have, that is the most anterior portion, or this is we call as the 1 out of 6 anterior portion of the eye. So that is our cornea. And this back side what we have, this one. So this is our outermost layer of the eye, that is the sclera. So that is the sclera. Okay, so this sclera will continue into the optic nerve sheath. Okay, this one will be continuing into the optic nerve sheath, and the area which is there here, this one, this area we call as the blind spot. Okay, so we call this one as the blind spot, right? Yes sir. And we have the innermost layers, that is the what we can say the sensory neuronal layer of our eye. So this is the retina we have. Okay, this is the retina we have. So retina is having the highest nerve supply. Okay, so that nerve will carry from here, so that nerve will carry from the here, so that is from the optic disc the nerve will get exit. Okay, and the blood supply is required, so the arteries will enter from here and the veins will get exit from here. Okay, so that is from the optic disc or from the blind spot. Sir, why we call that is the optic disc and blind spot? So there is no any rod cells, there is no any cone cells. Okay, so the most important thing we have to understand here. Okay, so if in case this optic disc is bulged inside like this, you consider this is bulged inside, which means the pressure is not increased inside the eye, so the pressure is increased here inside the cranium, so that is increased intracranial pressure, so which is creating the pressure over here and which is making the our optic disc to bulge inside the eyeball. So this is called as the papil edema. So this papil edema will be classically seen in the raised ICP. Okay, and the next very important thing you have to understand here. Okay, so if in case the intraocular pressure is raised, so that is considered case of the glaucoma is there. Okay, so that time this optic disc which is there here, it will bulge like this and the cuff will be formed here, because the pressure is raised here, means it will push it out. So that is the cuffing of the our optic disc is the raised ICP, and inward swelling of the our Optic disc is the increased, what we can say, intraocular pressure. I hope it is very much clear to every one of you, right? Yes, sir. So is that clear? Yes, sir. So here we have next. So the cupping of the optic disc, which indicates the glaucoma. So in the question, just if you are getting the clue, that is more than enough. Swelling of the optic disc and a papilledema word you are getting in the question. So what you have to think, immediately your mind now will get captures the word where is the intracranial pressure. Okay, so that is the how we will study with the integration of the clinical concept, integration of the anatomy, physiology with the medical surgical nursing, and makes the things fruitful to learn. Okay, this integrated learning is the actual thing you have to understand and you have to implement in your study, and while solving the question, this is actually makes you a champion. Okay, so now you have the lots of the clarity about the papilledema and optic cupping of the optic disc. So in a question line you are reading the word papilledema or the swelling of the optic disc, so then you will automatically think the rise ICP, right? So then you will automatically choose the right question. So this is how we have to clear the concept and move forward. Okay, reading the question is okay, so read the concept, understand the concept, and read the question. That is the double okay, and that is the okay for your selection. Are you getting the point? Yes. So that is most important, you have to understand, right? Yes, sir. Next we have is the, if we are finding the microaneurysm and the retinal hemorrhage, which will be seen in a case of the diabetic retinopathy. So pathy in the sense there is in the damage. Okay, so here due to the uncontrolled sugar there is in the damage to the retina, so there we are getting the micro aneurysm. Okay, small abnormally dilated blood vessels we have, so that is what we call as the microaneurysm or the retinal hemorrhage, which will be seen in the diabetic retinopathy, most important. And the cotton wool spot, so this is 5-star word, the cotton wool spot in the fundoscopy, where we will see this one will be seen in the hypertensive retinopathy. Okay, very important, right? Next we have the cherry red spot in the macula. So in the macula we are getting the cherry red spot, so that indicates the central artery, retinal artery occlusion. Okay, and there is in the pale of the optic disc is discolored into pale, which means optic atrophy have been happened. Okay, and the retinal detachment happened means, so there is the so the retina which is like looking like which is detached, so which will be seen in the retinal detachment disorder. So here we will see the cardinal sign as the floating of the curtain in the visual field. So that is the what we can say a retinal detachment. I am going to discuss that one in a very perfect way, so just stay connected, that's it. Okay, so yes, so what is the retinal detachment? So I told this is we have the 3 layers. Okay, so we have the 3 layers. So one is outermost sclera, middle one choroid, innermost retina. So this choroid is the pigmented layer which is having the highest blood supply among 3 layers. So among 3 layer, which layer is having the highest blood supply? So that is our choroid. Among the 3 layer, which one is the pigmented layer? That is our choroid. Okay, so that is very important. Among these 3 layer, which is having the optic nerve supply, that is our retina. Okay, so that is our retina. So this particular beautiful retina, now it is got detached from here, you consider. Okay, so it is usually attached with the choroid. So now this particular retina which is detached from here and which is falling in the visual field like this. So this is what you call the retina is came out of from here. So this is the detachment of the retina or the retinal detachment. Okay, so now it is floating in the vision. So you know the curtains of the window, how it will be floating. So it will be floating in the vision. So the classical clinical cardinal very important sign of the detachment of the retina is the floating in the visual field like a curtain. Okay, curtain like floating in the visual field, that is what we can say as the a case of the detached retina or the retinal detachment. Okay, so most importantly to be understand here, right? Yes, sir. So identify the image. Next most important thing, so this is your very important image based question. So this is 99% of the students will get confused. Okay, so what is this image? And I will show the another image. So now we see what is this image. Is that both are same or different? Both are 100% different. Both are having the 100% different role. Both are not similar at all. Okay. So what is this one? What is that one? Yes. What is this one? So this one is and the otoscopy. So this is the otoscopy. So in front of the otoscopy, so we are attaching this particular sharp object. Okay, so this is to see the inner layer or the inside portion of the ear perfectly. So the otoscopy is used for the visualization of the ear. Okay, this is for the visualization of the ear, right? Yes, sir. So that is the otoscopy what we have, right? So next is here we have the ophthalmoscopy, so which the front of this one is not sharp. Okay, so this one you can see in this image also. Okay, so are you able to see how the ophthalmoscopy is this? So the front of this one is not sharp, it is not sharp. Getting the point? Yes, sir. So the otoscopy front will be sharp. Okay, so that is the otoscopy and this one is the ophthalmoscopy. So this is how you have to identify. This is the ophthalmoscopy. This is the ophthalmoscopy. This one is used for the assessment of the inner eye. So this is used for the assessment of the inner eye. So this is most important, you have to understand, and from here you may get the question. Okay, so this is we also called as the fundoscope. Okay, so this is the we also called as the fundoscopy, that is the visualization of the inner eye. So that is also called as the fundoscopy. So I hope it is very much clear to be you can see here the ENT surgeon or the ENT doctor, so or the ENT nurse who is looking or inspecting the patient ear. So here you can see this is the otoscope. So the front portion of the otoscope is like it is sharp. Okay, so it is same like ophthalmoscope, but the front will be sharp, that is the otoscope, and the front will be blunt, that is the ophthalmoscope. So I hope it is getting to every one of you, right? Yes, sir. And here you can see the next question. Yes, what is the most common cause of the blindness in the India? The common cause of blindness in the India. Yes, so remember the most important C, 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 C. What it means, sir? If examiner asking you the question, the common cause of blindness is cataract. Clear? Common cause of blindness is cataract. Which cells are responsible for the color vision and the central vision? Cone cells are responsible for the color vision and central vision. This is the tricks you can remember. Okay, so that is C. Common cause of blindness is the cataract, and cone cells responsible for the central vision and the color vision. Getting the point? Yes. I hope it is clear in one shot, right? Yes. But the question is different like this. The most common cause of the blindness, which is infective, or the most common infective cause of the blindness. So is this cataract is the infectious condition, or is this a contagious condition? No. Even if I am kissing to an eye of the cataract, it will not spread to me, because this is purely a age related and this is purely a metabolic related problem of the lens. Okay, so this is not, it is non-infectious and it is not contagious, cataract. Okay, so but we have the one more very important common cause of the blindness, which is infectious, that is the trachoma. So we are going to discuss about the trachoma and the most important treatment strategy of the trachoma in a very perfect in this class. So just listen at the end of the class. Okay, so you will learn the knowledge like anything, and you will make this particular ophthalmology very easy, and I will make you to feel very easy. Okay, so that is the my promise from my side. Okay, so just I hope this particular question is very clear here. Okay, so if the question is common cause of the blindness in the India, cataract, common infectious cause of the blindness is the trachoma. So I hope it is very much clear, right? So answer goes to the, that is option B. To option B. Okay, yes, sir. And here you can see the most common cause of the blindness in India is the cataract. So that is the cloudy of the lens. So what is the cataract? So that is the claudication or the opacity of the lens. Lens should be usually and normally it should be perfectly transparent. Okay, so it is like a glass. It is like a glass. Okay, so it should be transparent. If even I am holding this glass in front of my face, you can see my face. Okay, so that is, it means it is the, this is transparent, this is purely transparent. If this particular lens is become opaque, so that is what you can call as the cataract. So what is the cataract? Cataract is the opacity of the lens, okay, or the cloudiness of the lens. So why it happens? It happens mainly and mostly due to the aging process. Okay, so this is usually seen in the old age people. That is what you call as the senile cataract. Okay, so the most common type of the cataract which we have also is the senile cataract. That is the most important. We will discuss about that one. Just understand what is the cataract. What is the cataract? That is the cloudiness of the lens or the opaque of the lens. So that is the cataract. Are you able to see this image here? So this is where the lens become completely cloudy and it becomes completely opaque. So this is how the eye of the cataract patient we can see. Okay, so normal eyes are not like this. I will show the how the normal eyes will looks with red reflex. Okay, you can see. So this is whenever we will see the patient eyes. So this is even after putting the light of the ophthalmoscope, so it will looks like this. Okay, so this is the what we can say red reflex. We have the normal red reflex. Okay, so even if the light of the ophthalmoscope is flashed on my eyes, so in my eyes also it will come like this, and in your eyes also it will come like this. So this is what you can say as the red reflex. Okay, so this is what you call as the red reflex. It is normally, it is 100% positive normally. Okay, it is present normally. Okay, yes sir. If in case the lens become opaque, so you can see, so here the red reflex is absent in the cataract. So we have the absent of the red reflex, and the lens will be seen completely opaque. So this is a very important thing you have to understand here. Okay, yes sir. And let me all the golden points to revise very quickly and very perfectly here. Cataract is just an opacity or the clouding of the lens, and which is actually a problem of the crystalline protein which is there inside the lens. Okay, so that is the very important thing, and this is the most common cause of the blindness in the India as the very important and the golden point. Okay, so question will come, what term we will use to describe the word of the clouding or the opaque of the lens? So that is the cataract. What is the most common cause of the blindness in the India? That is the cataract. Okay, so very important. The most other causes of the cataract what we have is, so that is the age related cataract. Okay, so this is the most common type of the cataract. So the age related cataract which we have is the senile cataract. Wherever the word you will get the age related, so always try to find the word senile. Senile is a problem which is associated with the age related. We have the senile vaginitis. Okay, so that is, there is the complete dryness of the vagina due to the menopause, due to the decreased estrogen. So because there is loss of the elasticity of the vagina, so that is what we call as the age is completed, menopause happened, estrogen decreased. So that is not in the condition of the infection and all. So that is just a condition which is happening to the aging process. So that is the reason we call that one as the senile vaginitis. So similarly here, so we have the senile cataract, means the cataract which is happening due to the aging process. So that is what we can say as the senile vaginitis. Sorry, senile cataract. Okay, so this is overall most common type of the cataract. So I hope it is very much clear, and this is 5-star point for your exam. Okay, yes sir. So 3-star, 4-star, and 5-star. Okay. Okay, sir. So I hope it is very much clear, right? And you become a next master nursing classes star. Okay, so next here we have the next type of the cataract. We have the congenital cataract. So this is due to the hereditary, and we have the cataract which happens due to trauma also. That is the traumatic cataract. Diabetic cataract we have, and the cataract which happens due to the exposure to the steroids and the radiation therapy. So these are the various type of the cataract we have. Not important, just remember the most common type is related senile cataract, and remember these are also a type of the cataract we have. Okay, yes, and the causes of the cataract we have. So that is next we have is the types of the cataract. Okay, so types of the cataract, we have the three types based on the which portion of the lens is involved. Okay, so if the middle portion of the lens, this one is involved, so this is a nucleus. So this is involved means that is our nuclear cataract. Okay, and here we have the capsule. Okay, so if the just a beneath portion or the outer layer cover of the our capsule of the lens is involved, that is the capsule cataract. Okay, so that is we have the subcapsular cataract. Okay, so that one I will discuss here. Then we have the the outermost layer is involved is the that is the subcapsular cataract we have, and the cortex we have is the this one. Okay, so this is the corticular cataract. So this is the corticular cataract. So what we have here is the corticular cataract, and this outermost layer is the our subcapsular cataract. So I will show the image perfectly, so it will be helpful. Okay, so this one will be the middle portion. If this one become completely opaque, that is the nuclear cataract we have, and this is the capsule what we are having. So that is the, are you able to see this black color line which is completely covered like this? So this one, that is the capsule we have. So just beneath of this capsule we have the cataract, means the opacity, that is the subcapsular cataract, and this complete cortex is involved. This is called as the corticular cataract. Okay, so this is called as the corticular cataract. So these are the, based on the involvement of the lens, we have the three types of the cataract. One is the nuclear, that is the nucleus is involved. Okay, so that is the nucleus is involved. Nuclear cataract is the central part of the our eye, that is the nucleus portion is involved. Okay, and cortical cataract is the, that is the cortex portion of the eye. So that is where the cortex in the cataract is developed in the cortex. Okay, so that is in the outer layer of the our lens. Okay, so that is we have, and here in the corticular cataract you have to understand it will starts with the edge of the lens and it will progress towards the center. Okay, and we have the posterior subcapsular cataract. So that is just below the capsule, and especially this one will happen at the posterior portion of the lens. So that is the posterior subcapsular cataract we have. So you can see, so this is, we have the lens and this is the capsule, and here the posterior subcapsular cataract. This is the opacity happening here means, so this is the posterior subcapsular cataract we have. Okay, yes, and so this one is occurring at the back of the our eyes and just beneath the capsule, that is the subcapsular. Okay, so I hope it is very much clear, and you can see the sign and symptoms of the cataract. So that is the opacity of the lens. So the earliest sign is asking means the classical clinical answer goes to the blurred vision. Okay, so this is the first priority, and decreased color perception, this is the second priority, and blurred vision is always and always first priority in your answer. Okay, so while choosing the earliest sign of the cataract, that is the blurred vision. If someone is asking you what is the late sign of the cataract, that is the milky white opaque appearance of the lens. Okay, so lens will be appearance like this. Okay, so it will be milky white and opaque appearance of the lens. It is looking milky white opaque appearance of the lens, that is the late sign of the cataract, and the most important one, early sign, will be the blurred vision. Okay, and normally in my eyes and in your eyes we don't have the cataract, so we have the normal red reflex. So what is the red reflex, sir? So there is red reflex in the sense the reddish orange color hollow it will be there, the reddish orange color glow or the hollow we have. So that one will be seen from the pupil when we will throw a light or when we will pass the light through the ophthalmoscope. So that will be reflecting as the red in color. You can see this is the red reflex we have. Okay, so when we will pass some light through the pupils on the retina, so retina will reflect in a red color. So that is the red reflex, in a very simple. Okay, so red reflex should be normally present. Okay, it should be normally present. In a cataract, what happens? So there is in the absence or the reduced red reflex will be there. So this is during the ophthalmoscopy. So we are getting the absence of the red reflex because the eyes will be like this. Okay, so lens will be completely opaque. Whenever we will see the ophthalmoscope, it will be seeing opaque, and whenever we will see with the bare eyes also, it will be seeing as the a milky white opaque. So that is what we have here, right? Yes, sir. So I hope it is clear. Yes. Options are reduced red reflex we have here. Okay, so I hope it is very much clear. Then we have eyes in the cataract, how it will be looks like I told. And remember, the cataract is not painful condition, it is completely painless condition, and it will not happen suddenly. It is a completely gradual condition, and the cataract is a chronic loss of the vision. It is not a acute condition. Okay, so cataract never be a acute, cataract never be a sudden, cataract never be a painful. It is mainly painless. Okay, so in a 90% of the cases it will be painless. I hope it is very much clear to every one of you, right? So here it comes to the next question. So try to read the question and try to give the answer for this one. Clarity of the concept is the very important. Okay, so that one you have to follow for your success. So we are just learning the question, and we are not revising the important images, and we are not revising the important lines and the types. So what is the purpose of that one? So we are studying the thing imperfectly, means that is not going to give the a result. So you study little, study better, study perfectly. So that is definitely going to improve your marks. So you don't have to score 100 out of 100 to get selection as a nursing officer. You have to score at least 60 to 68 marks to get the best, what we can say, percentile in the prelims, and to get score about the 110 to 115 or 120 marks to be in the top 100 in the mains. Okay, so just you are studying the whole thing imperfectly, that is not going to helpful. So study the thing which should be perfect, so that is going to be helpful. Okay, so here is the question we have, right? Yes. Which cataract surgery is defined as a procedure in which the cloudy lens, the opaque lens which was there in the cataract condition, that is broken into these small pieces. Okay, and using by the, how we have broken that one, by using the ultrasound waves. Okay, so by using the ultrasound waves we have broken that particular lens into these small pieces. Okay, so this one is very important, and we removed through the small incision. So we have made a small incision and we have removed all the small pieces which we have broken by using the ultrasound waves. Okay, so that is followed by the, we are implanting the intraocular lens. So that is what we can say as the IOL. So that is the intraocular lens implantation. So after removing the our old cloudy and waste lens which was there, so that is the opaque lens which was there, that one we are removing and we are replacing with a new one. So what is this procedure is called as? Okay, in which cataract surgery we will do this one? Option A, intracapsular cataract extraction. So here complete lens will we are extracting and we are removing. Extracapsular cataract extraction, phacoemulsification, small incision cataract surgery, SICS. So what is the correct answer? Yes. So the correct answer is the phacoemulsification. So phacoemulsification is the surgery where we will use the ultrasound waves, and we will broke the cloudy lens. Okay, so the cloudy lens or the opaque lens, what I have shown in the image, so that one we are breaking into the small pieces by using the ultrasound waves. Okay, so that is very important, right? Yes, sir. And we will make the small incision and we will take it out. So that is the surgical condition called as the phacoemulsification. Here we have the management of the cataract. So that is very important, you have to understand. So that is the intracapsular cataract extraction. So intracapsular means what happening here? So here the surgical procedure in which the entire lens along with its capsule is removed and we have like take out from the eye. So that is what we can say as the intracapsular cataract extraction. So here the entire lens along with its capsule is removed. Okay, so not only nucleus, not only cortex, not only capsule, so all three portions. So that is the nucleus, capsule, and the what we can say cortex part, everything will be removed. Okay, that is the intracapsular cataract extraction. Okay, so next we have is the extracapsular cataract extraction. So extracapsular means here what we are doing, surgery in which the lens, nucleus and cortex are removed. Only nucleus and the cortex we are removing, but the posterior capsule we are keeping intact. Okay, so only front portion of the capsule and the front cortex and the nucleus we are removing. Okay, so that's the posterior capsule is intact. So this is very important. So we are not removing the posterior capsule, it is the intact. Okay, so that is what we can say as the extracapsular cataract surgery. And we have the phacoemulsification. So phacoemulsification means, so that is the, this is the modern cataract surgery. So there we are using the ultrasonic waves, and the lens is broken into the small pieces by using the ultrasonic waves. Okay, and we will remove this one through the small incision. So this is followed by the like replacement of the new lens. So that is the intraocular lens implantation we are doing here. Okay, so that is to be a very important to be keep in our mind. Okay, so that is the IOL what I told. Okay, this is the procedure in which the artificial lens is implanted inside the eyes. So in the replacement of the removed natural lens, so that is after the cataract surgery. Okay, the natural lens is got opaque here, so that we have done the cataract surgery and we are replacing this one. So that is to be a very important, we are replacing with a new one, that is the intraocular lens implantation what we can say. And here it comes to the next question. A 60-year-old patient is there who is coming to the emergency department with a sudden severe eye pain. What happening here? The 60-year-old patient is there. This patient is coming to the emergency department with a sudden severe eye pain. So with a sudden and severe eye pain. Very important question. This is an 100% star question and having the highest chance to strike. So please do pay the special attention to this one. Okay, so important for the exam. There is in the 60-year-old patient is there and emergency department, he is coming with a sudden and severe eye pain. So can I say this is the cataract? No sir, because we studied the cataract, it is the not sudden, it is not acute and it is not painful. So here in the question, the three things mentioned, it is the sudden, it is the severe and it is the painful. So it is completely dead opposite of the cataract. In the cataract, there is no sudden, there is no severe and there is no pain we can say. Okay, and along with this one means I am removing the option from the cataract. Okay, yes sir. And next we have, as a patient also having the headache, blurred vision and seeing of the halos around the light. Okay, so patient is able to see the halos around the light. On examination, the eye is completely red, the pupil is mid-dilated and non-reactive to the light, and the intraocular pressure is very high. So here is the game changer word. Okay, so intraocular pressure is very high, it means it is the case of the glaucoma. So it is the case of the glaucoma. So in the option we have the two types of the glaucoma. One is the open angle glaucoma, another is the acute angle closure glaucoma. So now you tell me, so here the word which is mentioned, sudden, severe. Okay, so it means, is this the acute condition or chronic condition? It is the acute condition. So, and here we have the very important two types of the glaucoma to study in detail. So that is the open angle glaucoma and acute angle closure glaucoma. Okay, so the correct answer for this one goes to the option B, that is the acute angle closure glaucoma. Okay, so here the intraocular pressure is raised. So along with this one, severe pain, headache, blurred vision and seeing halos around the light, pupils are mid-dilated and non-reactive. So this is the classical clinical finding of the acute angle closure glaucoma. Okay, yes. Now you tell me, what is the glaucoma? Glaucoma is the condition where there is the increased intraocular pressure. Means inside the eyes there is the heavy increase in the pressure. Okay, sir, what is the normal intraocular pressure? So that is the 10 to 21 mm of Hg is the normal intraocular pressure. Sir, then when we can say glaucoma? When the intraocular pressure is more than 21 mm of Hg. When the intraocular pressure, if it is more than 21 mm of Hg, so we call this one as a case of the glaucoma. Okay, yes, sir. So this is the case of the glaucoma. So if it is happening gradually without causing the pain, first there is loss of the peripheral vision and only central vision is present. So we are unable to see anything from the side, only front which is there. So that is we are able to see. So that is what we can say as the tunnel vision. That is the open angle glaucoma. Okay, so that is painless. That is loss of the peripheral vision slowly, and that is due to the gradual increase in the intraocular pressure. And here the angle is open. So which angle? That is the angle between the our cornea and the iris. So that is open here. But the problem is there is in the blockage in the trabecular meshwork. So I will teach you that one with the image. It will be very much clear. Okay, so don't worry. So here the painless, gradual. Okay, and like loss of the peripheral vision first, then the central vision at the last. So when the loss of the peripheral vision, only central vision is present. So that is what we call as the tunnel vision. Tunnel vision is a classical seen in the open angle glaucoma. Okay, so that is open angle glaucoma. And another type of the glaucoma where we have, so there is a sudden, severe, okay, and heavy pain in the eyes. Okay, so that is happening very severe and suddenly halos are forming around the lights. Pupil are completely dilated here. So dilated pupils means angle is completely closed here. Okay, so pupils are mid dilated and non-reactive. So this means the angle is closed here. So this is the acute angle closure glaucoma. So now I am going to teach this one with the complete clarity of the image. So you will get the full clarity. What is the open angle glaucoma and what is the angle closure glaucoma. Okay, understand now here. So here we have the beautiful eye. Okay, so this is the eyeball we have. And the most anterior portion which we have here is that is the cornea we have. Okay, yes sir. And here we have the iris. This is the iris we have at the both side. Yes sir. Okay. Same remaining. Okay, so this is we have, and here we have the site. From here the aqueous humor will produces. So aqueous humor is the fluid which is present inside. So this is the side. So which side, sir? This one. That is the ciliary process. So ciliary process are the area where there is in the production of the formation of the aqueous humor will happens. Okay, so this cilia is continue into the choroid layer. So that is the mid layer of the our eye. Okay, this is the mid layer of the our eye. Similarly, here we have the ciliary bodies and the ciliary process, and here we also have the mid layer of the eye. Okay, so this one is the outermost layer, that is the sclera. We will see, make it as simple. Okay, yes sir. And here we have the most important, that is the jonular fibers, which is coming like a threads. Okay, so that is connecting the our lens to the, which is connecting the our lens to the ciliary body. So that is by the jonular fibers. So this is by the, we have the jonular fibers here. Okay, so this is the lens we have, right? Yes sir. And this particular portion, what we can say, the posterior one. So this is the, what we can say is the posterior segment. So this is the posterior segment. So let me write that one. This is the posterior segment, and which we have here, this one is the anterior segment. Okay, so anterior segment, which is started from the lens to the cornea, that is the anterior segment. From the lens to the vitreous body, or to the innermost layer, what we have here, one more layer we have, that is the retina. Okay, so this one, this particular one is the posterior segment what we have. Okay, yes sir. So here in the anterior segment, we have further divided this one into the anterior chamber and the posterior chamber. The anterior segment is further divided into the anterior chamber and the posterior chamber. Sir, how, sir? Listen here. So this one from the cornea till the iris, this one is anterior chamber. Okay, and from the iris till the lens, this one is posterior chamber. Okay, sir. So now I told this particular structure, that is the ciliary process, this is responsible for the production of the aqueous humor. Okay, so now my question is, where the aqueous humor will be produced? Aqueous humor will be produced in the anterior segment. Yes, sir. Which chamber of the anterior segment? That will be produced in the our most important posterior chamber of the anterior segment. Okay, yes, sir. So now here the our aqueous humor is produced. So this is how our aqueous humor will be produced, like here. Okay, yes, sir. So the aqueous humor which is produced here, so it will flow from the posterior chamber to the anterior chamber. It will flow from the posterior chamber to anterior chamber, and it will comes here, here like this. Okay, and in the anterior chamber, so here we have the angle, that is the angle between the our beautiful cornea. This red one is the cornea, and this is the iris. So this one what we have here is this is the cornea. Okay, and this is the iris. So between the iris and cornea, so this one is the angle what we have. Okay, yes, sir. So this is the angle what we have. In the angle, so we have a mesh like structure, so that is responsible for the drainage and absorption of the our aqueous humor. So that is what we call the trabecular meshwork. Same also here, the cornea we have, and the iris we have, and here we have the a trabecular meshwork. This is the canal of Leishman, or the trabecular meshwork we have. Okay, so aqueous humor, it will produces in the posterior chamber. It will comes front like this, and it will get drained and absorbed in the our trabecular meshwork. Okay, yes, sir. Now you understood the angle open glaucoma and angle closer glaucoma. So what happens here? In the open angle glaucoma, I will talk first. So in the open angle glaucoma, what happens? So this particular angle which is there here between our cornea and iris, this is open only. This angle is not blocked, but the trabecular, this particular trabecular meshwork we have, so this one is partially or completely obstructed. So the trabecular meshwork is partially or completely obstructed. So the production of the aqueous humor is happening, but the drainage of the aqueous humor is not happening. So aqueous humor is keep on increasing in the our anterior segment. So that is increased aqueous humor here means the production is there, absorption is not there. So that is causing the increased intraocular pressure. So the raised IOP always indicates the most important glaucoma. So when the IOP is increasing here, so what happens? So this intraocular pressure is increased here means, so in the back portion also we have the vitreous humor here. So here also the pressure will be created on the vitreous humor. So here also pressure will be created. So when the pressure is increased in the anterior segment, in the posterior segment also pressure shifted. So here the optic disc will be bulged out like this. So this is what we call the cupping of the optic disc. So this is what we call the cuffing of the optic disc. So this cupping of the optic disc we will see mainly in the raised intraocular pressure. Okay, yes, sir. So what happened in the open angle glaucoma? In the open angle glaucoma, this angle is open only. Which angle, sir? So that is the angle between the iris and cornea. It is completely open, sir. But the problem is this trabecular meshwork may get completely or partially blocked due to the any of its aging process or whatever it may be the reason. Okay, yes, sir. So then what happens due to this one? So there is in the raised ICP is there. This is creating the pressure over the anterior segment, and anterior segment pressure is shifted to the posterior segment, and here we have the pressure over the optic disc, and you know from here only there is in the exit of the our optic nerve happens, that is the second cranial nerve. So there is the pressure on the this cranial nerve, so there is the pressure on the second cranial nerve. So this pressure what I am having here, so this is increasing pressure on the a second cranial nerve, that is on the optic nerve, which will causes the blindness or the progressive blindness. This one will happen in the open angle glaucoma. Okay, yes sir. So then what is the acute angle closure glaucoma, sir? So let me teach you that one. Acute angle closure glaucoma is, so here what happens, the pupils are completely dilated, so and pupils are completely mid position. So let me remove all these things. Okay, so this one I'm removing. Okay, so I hope you understood this basic thing, right? So here what happened, you understand, this particular pupil are completely dilated, so means this particular iris is completely constricted. Okay, so iris which we have here, so this iris is completely constricted, means which is blocking this particular angle. Okay, so constricted iris is there. So iris is constricted means the gap between the iris, what happened to the gap between the iris, this one is the pupil. Okay, so that is dilated. So when the pupil is dilated, that time the angle is closed here, so due to the complete blockage of the our angle, so the drainage of the our aqueous humor is not happening. So again there is in the blockage of the flow outflow, and which leads to the increased intraocular pressure. So that is the reason the drugs which will dilate the pupils are absolutely contraindicated in the glaucoma, especially the atropine, because you know atropine is in the anticholinergic drug, which will be a sympathetic drug, and under the influence of the sympathetic nervous system, pupils will dilate. So pupils will dilate means there is more blockage of the our angle between the iris and the cornea. So that is complete blockage of the our angle. So where the again there is no obstruction of, there is no any drainage, the complete obstruction in the outflow. So that may causing the sudden severe increase in the intraocular pressure. So that is a medical emergency, that is acute angle closure glaucoma. So I hope it is very much clear. In the angle closure glaucoma, angle is closed. Okay, so that is because of the completely dilated pupils. Okay, and in the open angle glaucoma, so that is the angle is open and the problem is there in the trabecular meshwork. So there may be a age related degeneration or whatever it may be. So I hope it is very much clear. Okay, yes. So in the angle closure also and in the open angle also. So in the both the situation, the pressure will be there on the optic nerve. Okay, so that pressure is causing the blindness. Okay, that is the very important, and we need to treat that one as the a very priority and a very important priority. So that is we have to keep in our mind. Okay, yes. So here we have the most important golden points that you have to understand, and we have to correlate, and we have to revise immediately with a very important concept of the glaucoma. So just read once, so this will be helpful. Okay, so that is glaucoma. So what is the glaucoma? I told that is in the glaucoma is the group of the eye disorders which is characterized by the increased intraocular pressure greater than the 21 mm of Hg. Okay, yes sir. And this one is leading to the damage of the optic nerve because due to the increased pressure. Okay, and this one will causing the progressively vision loss because of the optic nerve or the second cranial nerve is getting compressed here. Okay, yes. Next we have normal IOP range. You have to remember there is the 10 to 21 mm Hg, and in the glaucoma it is more than 21 mm Hg. Yes. And we are having the types of the glaucoma. That is the two types of the glaucoma we have here. So the first one is the open angle glaucoma. Second one is the acute angle closure glaucoma. Okay. Yes. So I already told about the open angle glaucoma. What happening here? So open angle glaucoma is not sudden. It is the chronic. Open angle glaucoma is the chronic. Okay. Yes, sir. And where the drainage angle between the iris and the cornea are remains open. So the angle between the iris and cornea is completely open. But the problem is in the trabecular meshwork. Okay, so this trabecular meshwork is partially blocked, are completely blocked, which is causing the slowly increase in the intraocular pressure because the aqueous humor is not drained out properly. So, right, so that is the reason here the angle is open. Okay, so because of the trabecular meshwork problem, there is no drainage of the aqueous humor, so the IOP is raised. So that is called as the open angle. Means angle is open, that is the open angle. Rise IOP, that is the glaucoma. Okay, yes, sir. And we have the acute angle closure glaucoma. Acute angle closure glaucoma. So here there is in the acute, it means sudden will be there. Okay, and it is acute, it means it will be severe will be there. So this sudden and severe type of the glaucoma, where the drainage angle between the iris and cornea become completely blocked. Okay, so where the I told the angle, so that particular angle between the cornea and iris is completely blocked. So that is the a very important acute angle closure glaucoma we can say. And this one is leading to the rapid rise in the intraocular pressure. So rapid rise in the intraocular pressure is happening. So that is the sudden, severe and rapid. So sudden, severe and rapid. So that is what the things you have to understand and to be keep in your mind in the acute angle closure glaucoma. Okay. Yes, sir. So I hope the basic difference you understood here. Okay, so now let me teach the further distance like difference between the both. Okay, so the onset of the this particular chronic open angle glaucoma, so that is the slow and gradual onset is there, and acute angle sudden and severe acute onset is there. Okay, intraocular pressure is moderately increased in the open angle glaucoma because the complete blockage is there not there, so there may be a partial blockage of the trabecular meshwork. Okay, and there is a rapid and markedly increase in the intraocular pressure in the angle closure glaucoma because there is complete blockage in the drainage of the our aqueous humor. And the symptoms which is there here, usually painless with a gradual loss of the peripheral visions. So I told classically, so this is the tunnel vision. So this is one of the very important point for your exam, where we can see the tunnel vision. So tunnel vision will be seen in the open angle glaucoma. Okay, so what happens here? Due to the increased intraocular pressure, so first the peripheral vision will get lost. Okay, so peripheral visions are means this hand I am unable to see because this is in my periphery, and which is there in my front, only that one I am able to see. So it is like a I am looking something through this particular tunnel. Okay, so which is there exactly in front of this hole, so that one only I am able to see. So this is what you can say the tunnel vision. Okay, so this is a loss of the peripheral vision, only central vision is preserved, so that is tunnel vision. The tunnel vision is the classical clinical picture which we will see in a patient with a open angle glaucoma. Okay, and the clinical symptoms in a angle closure glaucoma, he will come to the emergency department, he will not come to the OPD, because this is a severe eye pain and headache, nausea, vomiting, and suddenly there is a blurred vision. So this will make the patient completely panic, and patient will run to the emergency department. So that is a medical emergency. We are going to take this one as a medical emergency. So very, very important, we have to keep in our mind. Okay, so there is sudden severe eye pain is there, right? Yes, sir. So appearance of the eye, so this is the gradual and chronic. This eye appearance normal only, no any redness in the early stages. Okay, but in the acute angle closure glaucoma, eye will be completely red, eye will be completely painful, and this will be like cornea appearance completely hazy. Okay, because he will rub that one. Okay, so completely like a peeled layer of the skin, like the corneal appearance. Okay, that is the very important. And we have the pupil. The pupil is usually normal. Here the pupils are completely dilated. So because of the dilation of the pupil only, there is in the blockage of the our like angle is there. So angle is blocked means, so that is the drainage of the aqueous humor will not happen. Okay, so pupils may be mid dilated and non-reactive. Okay, and visual disturbances, gradual loss of the peripheral vision. So that is the tunnel vision will happen. Sudden loss of the vision with halos around the light. Okay, so this is the classical we will see in a patient with the angle closure glaucoma. Okay, so that is most important. And nature of the condition, this is the chronic and progressive. I told this is the medical emergency, require the immediate treatment. Okay, so common age group, this will be in the older age because of the like there is in the age related problem in the trabecular meshwork. Okay, and here we have the more common elderly peoples. Okay, so those with a narrow entry chamber of the angle, so means the angle chamber is getting narrow. So in the mostly it will be seen in the elderly people. So I hope it is very much clear. So now you tell me the trabecular meshwork problem is there in the open angle glaucoma. So here we are going to do one surgery. So that is what we can say as the trabeculoplasty. So that is what we can say as the trabeculoplasty. So it is the repair of the our trabecular meshwork. Otherwise, we can so do here as the trabeculotomy. Trabeculectomy also we can do. So the trabecular meshwork will remove and will create a new area or the new channel for the drainage of the aqueous humor. Okay, so that is most important in this particular open angle glaucoma. Okay, in the angle closure glaucoma, first what we have to make, so first to stop the production of the production. So how we are going to stop the production of the aqueous humor? So I will give the beta blocker drugs. Beta blockers I will give, especially which is the drug of choice. So that is the timolol we will give. Okay, so timolol we will give. So here also we will give the timolol as a drug of choice. Okay, so here also we will give the timolol as a drug of choice. Very important. That is the beta blocker. Which beta blocker is used as a drug of choice in the like glaucoma? So in the glaucoma, the drug of choice which we are using is that is the timolol. Okay, so that is the very important, right? Yes, sir. So along with this one, I will give the like acetazolamide, that is the carbonic anhydrase inhibitor drug. So that is also I will give. And what I will do here, I will give the drug which will constrict the pupil. Here the pupil is dilated, means the iris is constricted, so that is closing the angle. So I am trying to open the angle here by giving the meiotic drug. So meiotic drug means so that I am trying to open the angle by constricting the pupils. If the pupils are constricted, means the angles will open. So that is very important. So I will give the meiotics. Okay, so I will give the carbonic anhydrase inhibitor, that is the acetazolamide, and I will also use the meiotics. Okay, so that is the meiotics. So this one is to open the angle. This is to open the angle. Okay, so in the meiotic, which drug I can give, sir? So that is I can give the cholinergic drug. So anticholinergics are absolutely, and the atropine is absolutely contraindicated. So in the cholinergics, which one I can give, sir? So in the cholinergic, I can give the pilocarpine. So pilocarpine. So is this the tablet, or is this the injection, or is this the what, sir? So this is in the eye drop. This is the eye drop pilocarpine we are using. Okay, so this is the very important drugs we are using here. Okay, so one is to stop the production of the aqueous humor, that is the beta blocker timolol, and carbonic anhydrase inhibitor acetazolamide, and the meiotic drug, so that is the used in the opening of the angle which was closed by using the cholinergic drugs, that is the eye drops pilocarpine. Okay, so and the surgery trabeculoplasty and the trabeculectomy will do. And here even after giving all these things, so this is not working, means we will go for the iridectomy, that is we will remove the iris of the what we can say, iris of the eye we will remove, and we will put the some shunt for the drainage of the fluid, and along with this one the partial iridotomy or iridectomy also we can do here. Okay, so I will teach all the surgeries together, so just remember here. Okay, yes sir. And here we have the next question, so that is just now discussed portion, so we can give the best answer and the correct answer. Okay, so question is which, very simple, which of the following drug is contraindicated in a patient with a glaucoma? So again this is very important question. Okay, so which of the following drug is contraindicated in a patient with a glaucoma? Option A timolol, option B acetazolamide, option C atropine, and option D pilocarpine. So just now only I told that, so we are using the beta blocker timolol to stop the production of the aqueous humor. Aqueous humor production be reduced, means there is no intraocular pressure, so glaucoma will be controlled. And I told we are giving the carbonic anhydrase inhibitors to stop the production of the aqueous humor, there is the acetazolamide we used, we are stopping the production of the aqueous humor. And we have the pilocarpine, that is the most important cholinergic drug. Okay, so this particular cholinergic drug, what it is doing, it is like which is constricting the pupil. Which is constricting the pupil means it is not blocking the angle, which is keeping the angle open. So that is the pilocarpine also will be used. And we have the atropine sulfate. This particular atropine sulfate, so this particular atropine sulfate which we have here, so this is the anticholinergic drug. So this particular anticholinergic drug atropine, if we are giving, so this is what I told, this is the anticholinergic. Okay, so this is the sympathomimetic also we can say. It will like work like a sympathetic nervous system activator. Okay, so this one will what it will cause, it will be a sympathomimetic, it will causes the mydriasis, it will cause the mydriasis. Mydriasis means pupils will get dilate. Okay, so pupils are getting dilate, so dilated pupils will blocks the our trabecular meshwork. So this will further block the trabecular meshwork. So block will increases. So block is increasing means there is the increased IOP further. So increased intraocular pressure further. So further increase in the intraocular pressure. Increased intraocular pressure further. So further increase in the intraocular pressure. This may leads to the worsening of the glaucoma. So that is the reason any drugs which will dilate the pupil or which will cause the mydriasis to be contraindicated in a patient with the glaucoma. So I hope it is very much clear. Okay, so you can see here. So we have the drugs which we are using in the treatment of the glaucoma. So that is carbonic anhydrase inhibitor, acetazolamide we have. Okay, so this will inhibits the carbonic anhydrase enzyme, so that is responsible for the production of the aqueous humor. So whenever we are inhibiting the carbonic anhydrase enzyme, so this will prevent the production of the aqueous humor. Okay, it will reduces the aqueous humor production and thereby it will reduces the intraocular pressure also. Next we have the beta adrenergic blockers or the beta blockers. In this one we have the timolol as a drug of choice. So this is used as the primary drug and drug of choice in the a patient with acute open angle glaucoma. So this will be very important. Okay, so timolol, and in the angle closure glaucoma also we will use this one, right? Yes. So next we have here is the most important, that is the miotic. Okay, so that is the miotic drugs we have. So now tell me whether the beta blockers will open the angle or it will close the angle. Beta receptors are the adrenergic receptors or the sympathetic receptors. If you are blocking the sympathetic receptors, what happens? There is no sympathetic nervous system action. No sympathetic nervous system action means no dilation of the pupils. No dilation of the pupils means no worsening of the glaucoma. So the beta blockers indirectly, which will cause the constriction of the pupils only, and the beta agonist will act as a sympathetics. Okay, beta agonists are again completely 100% is contraindicated, like a salbutamol, terbutaline. So these all things are the beta agonist, which is causing the pupil to get dilate. Pupil dilation will blocks the angle, so that we don't want. Okay, so beta agonist and the adrenergics, anticholinergics like atropine are absolutely contraindicated. Okay, and here we have the miotics. Okay, so miotics are the drugs. So we can see as the cholinergic drugs. So this is the here we have the eye drops pilocarpine. So this pilocarpine, what it will do? It will stimulates the muscarinic receptors. Okay, so here sir, uh, it is mainly stimulating the muscarinic receptors of the pupils. Okay, and it will cause the constriction of the pupils. Okay, that will cause the miosis. Miosis means the constriction of the pupils. Okay, so which will opens the trabecular meshwork and it will opens the angle. So this will helpful in the increase in the drainage of the aqueous humor fluid. So this is a drugs what we have, and we have discussed these three drugs. Okay, as the very important drug, that is the ATP. You have to remember what is the mnemonic to remember here. So that is the A, T, P are the drugs which we will use primarily in the treatment of the our glaucoma. So that is the acetazolamide, timolol, and the pilocarpine. So this one you have to remember, right? Yes, sir. And here it comes to the next very important question, and you must and should read this one, and you must and should give the correct answer. Already discussed one. Okay. Yes. So here we have question on the surgical procedure which we are going to do on the patient with the glaucoma. Okay, so that is very important. Yes. So what is the correct answer? What may be the correct answer? Which of the following procedure is commonly performed to treat glaucoma by creating the new drainage pathway for the aqueous humor to reduce intraocular pressure? So to drain the aqueous humor, so we are creating the new pathway. So in which surgery we are doing this one is the question. Which of the following surgical procedure is commonly performed to treat the glaucoma by creating the new drainage pathway for the aqueous humor to reduce the intraocular pressure? So this is the question. Option A is the trabeculotomy. Option B is the phacoemulsification. Option C is the keratoplasty, and option D is the blepharoplasty. Blepharoplasty means if something went a problem with our eyelashes, so that is if eyelashes are turned inward, so that is the what we call the entropion. Entropion means eyelashes which is turned inward and which is rubbing against our like mucosal layer of the our eyes, so that is causing the damage to the conjunctiva and cornea and to the sclera. So that time we will turn it out, so that is the blepharoplasty. We will do the repair of the our eyelids. And the keratoplasty we have. So the keratoplasty means we will do this one. So normally we have the this shape of the cornea. If the cornea become like a cone, the conus corneus, okay, or else the cornea become irregular in curvature. So that time we will going to repair this particular cornea. So that is what we call the keratoplasty. Okay, keratitis is the inflammation of the cornea, and the keratoplasty is the repair of the cornea. Okay, so this is also not a correct answer. And we also discussed already about the phacoemulsification, where we are using the ultrasonic waves and to break the lens into the small pieces, and we are taking out that particular small piece of the lenses by the small incision. So that's the phacoemulsification. We have done this surgery in the cataract. So now the question is, in a patient with the glaucoma, to create the new drainage pathway and to drain the aqueous humor and to reduce the intraocular pressure. So what is the procedure we are performing? That is the trabeculectomy. So we are removing the trabecle and we are creating the new pathway. That's the what we can say as a trabeculectomy. So removal of the trabecular meshwork. Okay. So here we have the various surgical options in the treatment of the glaucoma, and this is important chart for your exam. Okay. This is the important chart for the exam. So please do remember. Here we have the trabeculectomy. Trabeculectomy means a surgery in which a small opening is created in the sclera of the eye to allow the aqueous humor to drain out of the eye, so thereby reducing the intraocular pressure. So just thing you have to understand here, we are removing the trabecular meshwork, okay, and we are making the small hole in the sclera. So from that particular new opening from the sclera, it will be drained directly into the our episcleral veins. So all the aqueous humor will be produced, that will be drained into the episcleral veins. Okay, so that is what we can say trabeculectomy, removal of the trabecular meshwork and creating the new opening and allowing the drainage of the aqueous humor, that reduces the intraocular pressure. Next we have the laser trabeculoplasty. So trabeculoplasty means if it is partially obstructed, especially in the open angle glaucoma, so that time with the help of the laser we will repair the trabecules. Okay, so trabecular meshwork which was blocked, that one we will repair. Okay, so that is the laser procedure that one we are used to open the trabecular meshwork. So that is what we can say, by repairing the trabecular meshwork we are opening the trabecular meshwork and we are improving the drainage of the aqueous humor, which will reduces the IOP. Okay, so next is laser iridotomy. So means by using the layer we are just opening inside the iris. Okay, so the iris which is blocking the our flow, so that one we are what we are making a small hole in the iris. Okay, so with the help of the laser, that is the laser procedure in which a small hole is made in the iris, so that will allow the aqueous humor to flow from the posterior chamber to the anterior chamber very nicely. Okay, so that is what you can say laser iridotomy we have. Okay, and we have the iridectomy, complete removal of the iris. Okay, so the surgical procedure while the small part of the iris or the entire parts of the iris is removed. Okay, so this one is to create the new pathway for the aqueous humor flow. So this is also in the iridectomy. Okay, so next we have is the glaucoma drainage. implants. So that is the small tubes or shunt will be there. So that one we will keep in the trabecular meshwork. So there the all the aqueous humor will be easily get drained out. Okay, and we have the cyclophotocoagulation surgery. So this particular cyclophotocoagulation surgery, you have to remember this one. So this is in the a laser procedure. Okay, so that destroys the ciliary body. You know, from where the ciliary from where the aqueous humor is producing, so that is producing from the ciliary body. Okay, so this is a laser procedure that destroying the ciliary body only, so that decreases the production of the aqueous humor. So this is what we can say as the cyclophotocoagulation. Okay, so cyclophotocoagulation is the procedure where using the laser rays we are destroying the ciliary bodies. Okay, so ciliary bodies are destroyed means no aqueous humor production, so there is a decreased aqueous humor, reduced IOP. So I hope it is very much clear. Okay, so these are the surgical procedure what we have in the patient with the glaucoma. Okay, and here it comes to the next question. So to please do read the question. This is also I am going to give the very important question, especially the concept what I am going to explain after this question. That is the very important. Okay, so that is the very important. Please do pay the special attention on the concept what I am going to explain after this question. Okay, so next the question is very simple here. What we have, that is we have the 45-year-old person. So that is in the age of the patient is more than 40. Okay, yes sir. And the patient is complaining of the difficulty in the reading the small print and needs to hold the book further away to see clearly. Okay, and distance vision is normal. What is the most likely diagnosis? So he is telling that he is the first of all old age person, the 45-year-old age is there. So that is he is complaining his difficulty in the reading the small print. Okay, and to read that one he have to hold it further away, so then he is able to read like this. So he is holding away, then only he is able to see that one and he is able to read. When he hold near, he is unable to read. So this is the problem here. Okay, so 45-year-old person is there. So he is complaining of difficulty in the reading the small print and needs to hold the book further away to see clearly. Okay, so to see that word clearly, he have to hold the book further away. He have to hold it away. Okay, so not near, he have to hold it away. So then he is able to see it clearly. Okay, so distance vision is normal. So near vision is problem here and the distance vision is normal here. Okay, so what is the most likely diagnosis? What is the most likely diagnosis? Yes. So the two words we have here, one is myopia, another one is hypermetropia or the hyperopia we can say. So what happens in the myopia? That is, we also call this one as the nearsightedness. Patient is able to see the near thing and unable to see the far away thing. So that's the myopia. So here it is dead opposite in the question which we was given here. And in the hypermetropia, what happens here? So patient is able to see the object which is away from his body, so which is away from his vision, and he is unable to see the near object. That is the hypermetropia, the far-sightedness we have. Okay, yes sir. So which is given in the question. But this far-sightedness or hypermetropia, so this is given in an old age patient. So that is the answer goes to the presbyopia. So this one the examiner will confuse. Okay, so the patient is complaining the distance vision is normal and only like near vision is the problem, and that is happening due to the old person or due to the aging process. So that is the presbyopia. The refractory error that happening due to the aging process is the presbyopia, and the hearing problem that happening due to the aging process is called as the presbycusis. Presbycusis means that is a problem in the hearing due to the aging process. Presbyopia means the problem in the vision that is due to the aging process. Okay, so I hope it is very much clear. So the answer for this question goes to the option B. Okay, so now the question will come in your exam like what is the myopia, what is the another name of the myopia, and most important along with this one, so what other question will come is what lenses we will use in the treatment of this one. Okay, so that questions are the very important. Okay, so in the treatment of the myopia, what lens we will use? In the treatment of the hypermetropia, what lenses we are using? Okay, and the most importantly question will strikes also where the light rays are bending, whether the light rays are bending in the front of the retina or in the back of the retina. So where actually the light rays are bending, so that is the question which will comes in your exam. So just I will make a diagram and I will clear up just little bit of base of this one to choose you to correct answer. Then I will go to the in detail about the myopia, hypermetropia and astigmatism in detail. Okay, so understand here basically. So we have the one object here you consider. So this is one object what we have here. So this object we are seeing. Okay, this object we are seeing. Okay, yes sir. So here we have the eye. This is the eye. Okay, so this is the cornea of the eye and this complete outer portion, that is the sclera of the eye. Okay, yes sir. And here we have the iris. Okay, this is the choroid layer and this is the ciliary body and this is the choroid layer. Okay, similarly we have the iris and the ciliary body and the choroid layer. Okay, and the innermost layer which we have is that is the retina. The innermost layer and the sensory neuronal layer, where this particular image which how to come and reflect on this one, then only it will get converted into the photo in the our posterior pituitary. So that's it is in our occipital lobe, so that is not in the posterior pituitary, in the occipital lobe. Okay, so I hope it is very much clear. Yes, so let me make all the diagram first, so then I will explain the concept. So here we have the jonular fibers of the suspensor ligaments, so which is holding the lens in the place. Okay, which is holding the lens in the place. Okay, and okay, so this is how we have here. Okay, as an eye. So this is the eye. Okay, this is the structure of the eye. So here we have the lens and here we have the cornea. So this cornea and this particular lens, these both are having the function of the bending of the light rays. So light ray is coming from the top of this image and this is coming from the mid of this image and it is coming from the base of this image. Okay, yes. So these light rays will bend properly in a one particular area, especially over the macula lutea, and it will bend exactly in a on the retina. Okay, so it will not bend here, it will not bend here, it will bend exactly on the retina. So in the retina we have the optic nerve, so that will take a signals to the our occipital lobe. So in the occipital lobe this image sense will be like sensed. Okay, so this one will get sense in the occipital lobe. Okay, so now what happened here, if this particular lens is over bending the light, so if the lens is over bending the light, okay, so if the lens is over bending the light, means what happens, the light rays will over bend here, it will not go in front of the it will not go directly on the retina, it will bend in front of the retina. Okay, so it will bend in front of the retina. So that time what happens, person is unable to see the object from the far away, and to see this particular object he have to hold this particular object near. Okay, so you have to hold this particular object near, so then he is holding it very near to the body, means then this light rays will bend exactly on the retina. Okay, so this one will bend on the retina. Okay, yes. So if the light rays is bent, it means he is holding at the normal distance, that time the light rays where it was bending in the front of the retina. Okay, so he is unable to see this object which is from the far away distance. Okay, and whenever he is holding the object near, so that time the light rays are bending directly over the retina, so that time he is able to see the things, means the thing he is able to see from the near and the thing he is can't able to see from the distance. So this is what we call as the myopia or the near-sightedness, means he hold the object near, so that time the light rays will bend on the retina. If he is holding away, so light rays will be bending in front of the retina. So this is what we call as the myopia. So this is happening due to the over function of the our lens. So lens is in which like shape. So I told the lens will be in a biconvex shape. So this will be in a which shape? So it will be in a biconvex shape. So this is the shape of the lens we have. Okay, so here it is doing the over function means, so we will add the lens which is opposite of this one. Okay, so we will add the lens which is opposite of this one. So we will give the, in the treatment of this patient, we will give the biconcave lens. If we are giving the biconcave lens, so it will reduce the function of our over bending of the our normal lens. So this one makes the light rays to get exactly bend over the retina. So this is how we will treat the myopia. So in the treatment of the myopia, we are adding the biconcave lens. Okay, so we are adding the concave lens. So concave lens is having the function of the not converging of the light rays, it is diverging the light rays. Okay, so what it is doing, it is diverging light rays, and it is like normally it is over bending of the our light rays, it is dead, like it is opposite of the over bending, so it is making to bend the light rays normally over the retina. So that is in a nearsightedness, the treatment will be we are having as the concave lens. So this concept is very important for your exam to be, you have to understand. Okay, so let me take you to a beautiful ride. Okay, on the refractory errors, the first one we are having is the myopia. Okay, so we are having is the myopia or the nearsightedness. Okay, so nearsightedness, whatever the things which is near he is able to see, and whatever the thing which is away he is unable to see. Okay, so myopia is the refractory error in which near objects are seen clearly but distant objects are appear blur. So that is the myopia. Okay, so here you can see, here you can see. So normally what happening, it's this particular light rays which is there here, which is coming here, this one should bend here directly on the retina. So where it is bended due to the over function of this lens, it is bended in front of the retina. Okay, it is bended in front of the retina. So in order to treat this one, what we are going to do, so we are going to add the this particular lens, the concave lens. Okay, so when we add the concave lens, so now it will diverge the light rays, it will diverge the light rays. Okay, it will diverge the light rays, and it will not allow to bend in front of the retina, it will allow to bend the on the retina exactly. So this is in the treatment of the myopia. So what we are giving, so we are giving the concave lens. Okay, so this concave lens, what it is doing, it is diverging the light rays. This is diverging light rays. So this is a very important thing you have to keep in your mind. I hope it is very much clear. Okay, yes. So the main problem what I told, the light rays where it is bending. So problem is light rays is focusing in a front of the retina, not on the retina. So that is the main problem. Okay, so the bending of the light here due to the over function of our lens, the over bending of the light is happening, or the excessive refraction is happening. So that is the excessive conversion is happening. So the light rays is bending in front of the retina. Treatment is we are adding the concave lens. We are adding the concave lens. So that is diverging the light rays. Okay, that is the diverging the light rays, and this is allowing the like light rays exactly to get focus over the retina. Okay, so this is the very important. Next we have effect of the lens. So that is a concave lens will diverge the light rays. Okay, so this is helpful in the focus of the retina. Okay, so that's the very important. Next we have the another refractory error. So that is we also call as the hyperopia, hypermetropia, or the farsightedness. Okay, so here what happens, sir? So here what happens in the sense, same image I will take you for the explanation of the concept. Okay, you can see here. So you can see here. So I am removing this thing. Okay, so just same image, you understand. Normally what happens, when our lens will be functioning normally, it will bend the all the light rays exactly over the retina. That is the normal thing. Okay, so here this lens which we have here, this lens which we have here, so this is reduced its function, so decreased function, or the decreased bending of the light, decreased bending or the decreased refractory ability of this particular lens. So now the light rays are not bending here on the retina, light rays are going behind the retina. So here light rays are bending. Okay, so not in front, also not over bending, means it will bend here. If the over function of the lens means it will bend here. Okay, so normal means it will bend over the retina. Okay, it is reduced function means it will bend behind the retina. Okay, so light rays are bending behind the retina. So that time if something he is holding near, so again the light rays will go more behind the retina, so he is unable to see. Means if I am holding here away, so that time the light rays will bend over the retina. How you can see? So here, if this particular image what you have here, this one I am keeping away here. If I am keeping away here, okay, so I am making it to be away here. Okay, so I am taking out from that particular thing and I am keeping away here. That time this light rays will be coming back and it will bend on the retina. So in the hypermetropia or the hyperopia, what happens is, so the light rays are bending behind the retina. When I will keep that object away, that time the light rays will bend on the retina. Means the object which is away from the body and which is in the far away distance I am able to see, and which I am holding near I am unable to see. So that is what we can say as in the, that is what we can say as in the hypermetropia or the hyperopia or the far-sightedness. Far-sightedness, the far away images he is able to see clearly, and near images he is unable to see clearly. So he is unable to see near images. Why? Because so whenever he will hold the images near to him, okay, so whenever he will hold the object images near to him, that time this light rays will bend behind the retina. Okay, so that time he is unable to see. So similarly, he is keeping it at the normal distance, that is okay, and he is keeping away from the normal distance, then only light rays are bending. Means the far away object only is able to see, and the near he is holding means light rays are bending going behind the retina, so that he is unable to what we can say see the near object. So that is what we can say as the very important farsightedness. Okay, so in the farsightedness problem is the lens is having the decreased function. So then what we will add? So we will add the one more same shape lens here. So this one. So this one will improve the light bending ability. So in the treatment of the farsightedness, what I am giving? I am giving the convex lens. I am giving the convex lens. So this convex lens, what it will do? It will bend the light rays. Okay, it will bend light rays on the retina. So that is the it will converge the light rays. It will not diverge. It will converge the light rays. So this is very important for the exam. So I hope it is very much clear to every one of you, right? Yes, sir. And here we have the hyperopia or the hypermetropia or the farsightedness. Okay, which means a person or the patient in the hyperopia is, this is actually a refractory error in which the distance objects are seen clearly but near objects are appear blurred. Because if you are holding the object near, so that is a light rays are bending behind the retina. Okay, so that is hyperopia. So if I am adding the same shape one convex lens here, so that is helping for the making the light rays to bend properly over the retina. So this is a convex lens I am adding. So this is converging the our light rays. So I hope it is very much clear. And the problem here is, the main problem here is the light rays. So this light rays, where it is bending, so this is focusing behind the retina. That is the problem in the hyperopia. Okay, so bending of the light rays is less. So that is the reason we are adding one more convex. Okay, so that is which will helpful for the bending of the light rays. And the treatment for this one will be the convex lens. Convex lens we are having. Okay, and effect of the lens is, so that is the convex lens converges the light rays. So this is the very important, and it will helpful for the focus on the retina. Okay, so light rays will bend on the retina. I hope it is very much clear. Yes, sir. And this hypermetropia, which is happening due to the aging process, that is what I can say is the presbyopia. So same patient, the old age patient will be there, age more than 40 years. So he is complaining same thing which was there in the hyperopia. So that is, whenever he will hold the near, he is unable to see. Whenever he will hold the far away, he is able to see. So due to the aging process, hypermetropia is happening. That is the presbyopia. Okay, so presbyopia is the a age-related loss of the eye's ability to focus on the near object. Okay, so he is losing his ability to focus on the near object, so he is unable to see the near object, and the far distance object he is able to see. So what I can say is the a hypermetropia or the hyperopia in a old age patient, that is the presbyopia. Okay, the cause of this one will be the loss of the elasticity of the lens, which is due to the age process, and age is usually behind the 40 years and more. Problem is decreased accommodation of the lens. Lens is not accommodating as per the need of the patient. Okay, so that is the very important. Next is light rays. So this is a near object are tends to focus behind the retina, so that is the reason he is unable to see the near object. When he will hold it far away, so that he is able to see, because the near object which is looking, so that is the light rays are bending behind the retina, so he is unable to see. So here we are using the convex lens, same as the treatment of the what we can say hyperopia, and in some cases we will use the bifocal lens also. This one will improve the accommodation. Okay, so that is bifocal lens we are using here. Okay, and while reading we will add on the reading glasses. So this is the very important point we have to keep in mind. And we have the next very important condition, that is what we call as the astigmatism. So this is also refractory errors. So what is the problem in the astigmatism? So problem in the astigmatism is, so you understand here we have the normal shaped lens we have. Okay, so you can see normal cornea we have. Okay, so here we have the normal cornea we have, and normally lens we have. So this, if in case this cornea is having the abnormal curvature like this, and if this lens is having the abnormal curvature like this, so the abnormal curvature of the cornea and abnormal curvature of the lens, so what it is making, so it is making the light rays, this is making the light rays to get focus on the multiple sides. So this is making the light rays to get focus on the multiple sides. So this is what we call as the astigmatism. Astigmatism is the very simple thing and a very important thing where we have to understand there is an abnormal curvature of the lens and abnormal curvature of the cornea, which is making the light rays to get bent in the multiple side. That is what we call as in the most important, that is astigmatism. Okay, so the question will come, what is the term we will use to call the astigmatism? Astigmatism we are using to call the word, we call that one as in the most important abnormal curvature of the cornea and the lenses. Astigmatism also in the refractory problem, which is caused by the irregular abnormal curvature of the cornea and lenses, which is resulting from the distorted and the blurred vision. Normal vision is not getting possible here. Okay, so the main cause will be the irregular curvature or the irregular shape of the cornea or lens. Okay, so light rays are focusing on the multiple points instead of the one point, it is focusing on the multiple point. Treatment will be the cylindrical lenses we are adding here. So this is the very important to be keep in our mind. Okay, so here the astigmatism lens we are using is the cylindrical lens, and in a case of the presbyopia, so we are using the what we can say as in the convex lens, and we are also using the bifocal lens, and most importantly we are using the concave lens in the myopia and convex lens in the hyperopia. Okay, so that is the thing what we have to understand. Okay, so you can see normally vision is like normal curvature of the cornea we have, normal curvature of the lens we have. So this is focusing exactly over the macula lutea, you can see. So exactly it is focusing over the macula lutea on the cornea, sorry, on the retina. Okay, yes sir. So if this particular, you can see this is abnormally curved, so it is over curved. Okay, and it is like a flat here, you can see. So because of this abnormal curvature of the our lens, so due to the abnormal curvature of the our cornea, so the like at the multiple site, at the multiple site the focal point is generating. Okay, so this is causing the what we can say astigmatism. So that is, I hope every one of you are very much clear. Okay, and here we have the next question, very important question and very important question. So today we are going to completely cover the ophthalmology, so that is much necessary for the exam, and from there you may expect the question in the exam. Okay, yes sir. A 55-year-old patient is there. so who suddenly flashes off the light. So what he is getting, he is noticing, he notices a sudden flashes of the light is there, and there is multiple floaters are there, and dark curtain like shadow is moving across the field of the vision. The very important clue. So already I have told the curtain like shadow which is there in the visual field. So where we are seeing this one is the window of the curtain, how it will be float like this. So like that only our retina is detaching from the choroid and it is floating like this. So in the retinal detachment, the classical clinical picture, that is the curtain like shadow moving across the visual field. Okay, so in one eye it is happening like this. The vision becomes progressively blurred, but there is no pain, okay, and there is no redness in the eyes. What is the most likely diagnosis? What is the most likely diagnosis? The question is, the options are cataract we have, and the retinal detachment we have, and acute angle closure glaucoma we have, and the conjunctivitis we have. So what is the correct answer? What is the correct answer? Already discussed. So this one will be classical seen in the retinal detachment. So what happens here? There is no image. I will make the image. Okay, so don't worry. So here we have eyes. Okay, so that is, we have the eyes, and here we have the cornea. Okay, so here we have the choroid layer. Okay, so this is the iris. This is the iris. Okay, so this is the second layer. What we have, this is the choroid layer. Okay, this is the choroid layer. In attachment of the choroid layer, so this is the second layer, the choroid layer. In attachment of this one, we have the innermost layer, so that is the, what we can call as the retina. So this particular retina is the innermost layer which is directly in attachment with the our choroid. Okay, so this is the retina what we have, which is attached with the choroid. Okay, so now in case this particular retina which was there, it is attached with the choroid, so what it will do, it will get detaches from the our choroid. Okay, so retina will be now detached from the choroid and it will be coming like this. Okay, it will be coming like this. So this is called as the detachment of the retina. And now this particular portion which is there here, so this is there here, so this one is like a curtain of the window. Okay, so this is like a curtain of the window, and in the visual field there is, and the, so like externally nothing is there, so still the patient will feel some curtain is flowing in the visual field, so some fluttering is there in the visual field. Okay, so this is what we call as the curtain visual, like what we can say, the very important retinal detachment, and where we are seeing the classical clinical picture, so that is the curtain like shadow which is moving across the visual field. Okay, so this is a retinal detachment. Okay, yes sir. And retinal detachment, this occurs when the neurosensory layer, that is the retina, is gets separate from the underlying retinal pigmented epithelium or from the choroid. Okay, we can say the simple word, retina is separated from the choroid. Usually retina is attached with the choroid, now it is detached. Okay, so it is usually painless but causes the sudden visual disturbances. Okay, suddenly there is in the floaters will be there. Okay, suddenly there is in the flashes of the light is there, so that is what we call the photopsia. Okay, so flashes of the light the patient will feel, and the floaters in the vision is there, and the classical clinical finding, that is the curtain or the shadow over the visual field is there. Okay, and this all thing will be happen suddenly, and the sudden decrease in the vision also will happens because the main layer which is responsible for taking the sensation, so that is the retina become here the what we can say detached. Okay, so that is the reason the vision will get decreases here. Okay, and most important nursing intervention, whenever the patient will be comes with you with the detachment of the retina, always and always encourage the minimal eye movement, because more eye movement, more detachment will happens, and advise the patient to avoid the sudden head movements. Sudden head movement should be completely avoided, and apply an eye shield if prescribed to protect the affected eye. So if you want to protect the affected eye, so apply the eye shield. So that is the very important Very important. If you are not covering the eyes, so he will be see here there, and again the retina will get detaches. Okay, and most importantly, prevent the rubbing and pressure over the eyes. So these are the important nursing intervention to be followed in a patient with retinal detachment. In this one, the most important one will be the apply the eye shield. So this one will helpful in the further detachment of the our retina. So this is very important point you have to keep in our mind. Okay, so this is very important point we have to keep in our mind. So that is the, I hope it is clear. Okay, so here we have the some treatment option. So that is most important for the exam. So that is the surgical treatment of retinal detachment of of the retinal detachment. So how we are going to treat the retinal detachment? So retina is got detached, so we are going to reattach that one. So how, sir? You can see in this image, that is by applying the buccal or the sclera. So this is detached retina, you can see here. So this is the choroid layer we have, and here the retina which is come out. Okay, this is the detached retina. So here we are applying the buccal over the our eyeball, so that will be compressing the eyeball, and it is helpful for the reattachment of the our retina back. Okay, so this is after the procedure how we'll see, and this is the detached retina. So this is called as the scleral buckling. Okay, and we have the pneumatic retinopexy. So that is we are pushing some gas bubble inside the our eyes. Okay, so that is in the eyeball, pushing the gas bubble. Okay, so this gas bubble is push like creating the pressure over the retina, and retina is going back and attaching to the choroid layer. So this is what we call the pneumatic retinopexy. Okay, so the bubble gas is there, so that is which is like helpful for the reattachment. Okay, so along with this one we have the other option also, you can see here. So that is the scleral buckling. I told what about the scleral buckling? Scleral buckling is the, so this is a silicon band we are applying. Okay, so which band we are applying? We are applying the silicon band which is placed around the sclera. So this one is helpful for the pushing the eye wall inward. Okay, so it is pushing the eye wall inward as just shown in the image, and that one will be helpful for the attachment of the retina back to its underlying layer. Okay, so that's the very important. Next we have the pneumatic retinopexy. In the pneumatic retinopexy, what happening? The gas bubble is injected into the vitreous cavity. So that gas bubble is creating the pressure and putting the retina back against the wall, and it is helpful for the reattachment. Okay, and we have the vitrectomy. Vitrectomy means, so that is the vitreous gel is completely removed surgically, and it is completely replaced by the gas oil of the silicon. So this gas oil of the silicon will create the pressure over the retina, and retina will go and attach back to the our choroid layer. That is the vitrectomy we will do. And we are going to do the laser photocoagulation. So this one it is a laser induced surgery where we are creating the small burn around the retina. So where it is got tear, so that particular area we are creating the small burn where it is causing the inflammation, and adhesion will happen. Okay, so retinal tear in that particular area we are creating a small burn. Okay, so this is helpful for the reattachment of the retina. So that's the our laser photocoagulation. Next we have the cryopexy. So in the cryo means, wherever the word cryo comes means it is the use of the excessive cold. Okay, so here we are using the excessive extreme cold we are using. So we are applying to the eyes. Okay, so especially walls of the eyeball. So here it is helpful for the freezing and shield the retinal tear. Okay, so this is then the cryopexy we are using. So I hope it is very much clear to every one of you. Okay, and here we have the images of the scleral buckling, which may come as the image based question also. And here we have the pneumatic retinopexy, that is also a very important question. And here we have the next question. So please do read the question properly, perfectly, then try to give the answer. A child is there from the rural area, so he is presenting with the chronic redness. Okay, so there is the chronic redness of the eyes are there, and he is having the irritation, tearing, and repeated eye infection. Repeated eye infections are there, means very frequently eye infections are happening. On examination, there are the follicles on the inner surface of the eyelids. So in the inner surface of the eyelid, there is in the follicles, means there is in the turning of the eyelid like this. So that is called as the trichiasis. Okay, so that is follicles on the inner surface of the eyelid, and that is scarring the conjunctiva. When we will close the eye, open the eye, so that time the follicles, the hair follicles which is there, which is turned inward, so that will irritates the eye, like our conjunctiva, and it will causes the tearing of the conjunctiva. Okay, so follicles in the inner surface of the eyelids, okay, and which is scarring the conjunctiva, if untreated, it may lead to the inward turning of the eyelashes, which may leads to the inward turning of the eyelashes completely. That is called as the trichiasis. Okay, and we can say entropion also, and cornea will completely damage it. What is the most likely diagnosis of this condition? You tell me. So very simple thing is, where the repeated eye infection will happens with the trichiosis. So this is the clue here. Repeated eye infection, and follicles are there in the inner surface of the eyelid, and the trichiasis is happening. So what is your answer? So that is the trachoma. The answer is trachoma, or the chlamydial conjunctivitis. So this inflammation of the conjunctiva due to the trichiasis, so due to the inward turning of our eyelashes, which is rubbing against our conjunctiva, and the inflammation is happening, and the chronic redness of the eyes are there, completely irritation, completely continuous tearing. So repeated eye infection happening means that is the classical answer goes to the trachoma, and the trachoma is the most common leading cause of the infective blindness. Okay, so infective blindness, most common leading cause is the trachoma. So very important, right? Trachoma is the chronic infectious of the eye. So this is caused by the chlamydia trachomatis. So this is a very important one, and examiner favorite question. So this is examiner favorite question. All right, yes sir. So the trachoma is the most common infective cause of the blindness worldwide. Okay, so we have discussed this point already. Next, overall most common cause of the blindness in India is that is the cataract, and most common infective cause of the blindness is the trachoma. Okay, and common sign including, so that is the follicles are there in the conjunctiva, chronic inflammation and repeated infections are there, especially trichiasis is there, that is the eyelashes are turned inward. Okay, and cornea is got damage leading to the blindness, and if we are not treating that one properly, so that is going to cause the blindness. Okay, that is the very important. So how it is getting transmission, sir? So this is getting transmission by the direct contact, okay, and by the contaminated towels, cloths, kerchiefs, and the flies also. So here the treatment goes to the environmental control and environmental improvement also, because this is getting transmitted by the flies also. So the target of this or the strategy of the treatment, which including the environmental control and control of the flies also, that is the very important. Okay, so that one I will teach you in the strategy, right? So how it is getting transmission, we know by the direct contact, by the sharing the towels and the kerchiefs and the cloths. Okay, so that is the reason whenever the patient will admit with the conjunctivitis, that is the contaminated conjunctivitis, first primary, like best intervention we have is we have to educate to the healthcare providers and to the caretakers of the patient also, the frequent hand washing. Okay, hand washing frequently is the very important word. Okay, so that is the frequent hand washing is the main strategy which will prevent the transmission of our trachoma. So this is the very important, and this is the single best intervention. So you tell me one of the very best intervention to me to control the spread of the trachoma. So very best intervention we have is the frequent hand washing. Okay, so every time. Along with that one, don't share the contaminated towels, cloths. Every time you are cleaning the eyes, clean with a like sterile cotton or with a like fresh tissue paper you can clean. Okay, so don't repeatedly use the one cotton and one tissue paper. Okay, so this is very important, and this is common in the poor hygienic and overcrowded areas. So we have the treatment strategy to prevent this particular trachoma. So that is the SAFE strategy. What is the meaning of the SAFE strategy? So here the S stands here is the surgery for the trichiasis. Inward turning of the eyelashes is there, continuously irritating the conjunctiva. You make it turn outward, otherwise it will causes the blindness by damaging the sclera and cornea. Okay, so first one is the surgery. So that is for the trichiasis we are doing the surgery. And antibiotic, A stands here as the antibiotic. Azithromycin we will use because here it is happening due to the infection of the chlamydia trachomatis. Okay, that one we want to destroy. So we will use the antibiotic. And this is happening in a poor hygienic condition. The facial cleanliness is the classical thing to be maintained here. Okay, and this is gets spread by the flies also, and by the contaminated crowded areas also. So the environmental improvement is the E here. Okay, so question will come in a strategy of the SAFE. Okay, so what is the E stands here? So in the SAFE strategy of the control of the trachoma, E stands here is the environmental control. So what F stands here? That is the facial cleanliness. What is the A stands here? That is the antibiotics. What is the S stands here? That is the surgery for the tracheasis. So this is a very important. We have to keep in our mind. And the nursing interventions we have. So that is the patient education to prevent the trachoma. Same thing I already told. Wash the hand very frequently with the soap and water. This is a very important intervention and the very best intervention. This is the always best intervention. Okay, so along with this one, so avoid touching or rubbing the eyes with the unclean hands. So you don't have to touch the hands with the unclean hands, and don't use the one cotton or the one tissue paper for the repeated cleaning. Don't use that one. Okay, and clean the face and eyes regularly, especially in the children's. And do not share the towels, handkerchiefs, pillow and cosmetics of the eyes, eye drops. In the conjunctivitis, don't apply any cosmetics to the eyes. Okay, especially in the children's. Mother are like just give me a second. Fine. So here, most importantly, mothers are very interested to apply the cosmetics to the eyes of their own children. Okay, if in a case of the conjunctivitis and the trachoma, we educate them not to apply any cosmetics to the eyes. So this is very important. Okay. Yes. So here is the next question. Here the question is very simple. The question is on the a very important topic. Okay, that is in a 3 days old newborn, there is and the development of the redness of the both eyes. Both eyes are got red, and there is a swelling is there. Swelling of the eyelids are there, and there is profuse purulent sweating is there, and a profuse purulent discharge is there. 3 days newborn is there. Redness of the both eyes are there. He is a 3 days newborn, means within 28 days of the life, what happened? The eyes are become swollen, red and purulent, means the conjunctivitis happened within 28 days of the life. So what we call that one? Yes. What is the term we will use? The conjunctivitis which is happening within first 28 days of the life, that is the ophthalmia neonatal. Okay, so here is only our answer. Still we have to read the question completely. Okay, so the baby was delivered vaginally. Yes, so highest chance of the transmission is there during the delivery time. So that is the during the perinatal time. So that is baby is coming out and the mother is having the infectious birth canal. So from the mother birth canal, the infection is transmitted to the baby. This is the most common route of transmission of infection in the ophthalmia neonatal, that is from the mother birth canal to the eyes of the baby. Very important. Okay, yes sir. And baby was born per vaginal delivery, and here is the mother is having the untreated genital tract infection during the pregnancy. So what is the most likely diagnosis? So usually the diagnosis and answer goes to this one is the ophthalmia neonatal. The ophthalmia neonatal is the very important thing here. So what is the ophthalmia neonatal? That is the a conjunctivitis is happening in a first 28 days of the life. So this is called as the ophthalmia neonatal. Okay, most common cause is the Neisseria gonorrhea is the most common and the most severe cause, and second most common is the chlamydia trachomatis. Okay, so that is the most common is the Neisseria gonorrhea, and second one is the chlamydia trachomatis where the trachoma is happening. Okay, most important. Next we have is the mode of transmission. So mode of transmission occurs during the passage of the baby through the infected birth canal. So baby is coming out of the infected birth canal, so that time the transmission is happening. So that is the mode of transmission. So drug of choice as a prophylaxis to prevent the infection of the ophthalmia neonatal. So very important, that is the erythromycin ointment 0.5% we are using. Okay, so immediately after the birth we are applying to the eyes of the babies. That is the which ointment? So that is we are applying the erythromycin 0.5% of the ophthalmic ointment we are applying to the eyes of the baby immediately after the birth if the mother is having the any history of the Neisseria or the chlamydia trachomatis infection. Okay, so that's the very important. And this is not only that just important, this is a very important point, and this is multiple time asked question in the exam. Okay, yes sir. So here we have the next question. A nurse is administering the eye drops to a patient. After instilling the drops into the conjunctival sac, which action should the nurse perform to reduce the systemic absorption of the medication? So this is your assignment question. So every one of you, please do choose the correct answer of this one and put the answer in your app chat box support and in the comment box of this particular class. So we will meet again with the next 4 to 5 questions are remaining, and that including the ophthalmic emergencies like a flash of the chemicals and the what is the exact timing of the flushing with the water, everything. So that's the most important we have, and we have the few more terms on this one. We will continue this one in the next part. So thank you so much for watching the class here. Bye bye, take care, we will meet again, and I hope you enjoyed the session and you learned the lots of the thing. So notes will be available in the A1 plan, A2 plan both. Okay, so in our crash course plan. So please do revise the notes immediately after the class. Okay, and most importantly, you have to solve the MCQs from the your MCQ book. So that is what we have discussed till now here. Okay, so thank you so much for the watching the video till here, and we will meet again with a more beautiful content in the next class. So tab tak ke liye Jai Hind, Jai Bharat. If you are new to our channel, so please do subscribe to the channel, and please do share this particular information with your friends. There is the legendary learning is going on with the clarity of the concept for cracking the any state and central government exams. So please do share this information with your friends. It will help us to improve our community. So that will help us to build the master nursing community more strong and more strong. Okay, so thank you so much for the watching the video till here. Bye bye, and I am expecting your answer in the chat box and comment box also. Thank you so much. Bye bye. Take care. Jai Hind, Jai Bharat.